Thank you so much for having me up here again. And sorry for speaking again about kind of the same thing maybe, but I'm sure there's maybe some other people who know a lot about digital medicine, and I'm very happy to hear their input. But well, that's how we are now. So I want to tell you a bit about a few projects we do that came out of Charité or are available in Germany, maybe to inspire also some new things. And first of all, I want to say I really love Gita's project, or the whole Better Balance project, and I can't wait to see this happening in Germany. I think this is really what we need. And this is also, I wanted to ask a question now, maybe we can ask it in the context of this presentation as well. And because I think the most important thing, if we think about establishing medical technologies and new digital devices, is about sustainability of these and having them available in different countries and having someone this as a project that's financing itself somehow and it's not dependent on grants and other things. So I think having a trial, having devices regulatory approved is going to be so important, and this is going to be a big challenge, and I really hope this works, and I'm looking forward to seeing it in Germany as well. Again, this, you've seen it already. I will again talk about the problems that we have and then some digital care aspects that we might all together consider, and I'm happy to hear other ideas as well. So the problem, as we know, we are a lot of people, but we are dispersed all over the world, so it's really hard to get the cohorts together and to reach all the patients, and for the patients to reach us or care. Another problem is that it's really time-consuming and really hard to look at all these patients. We have lots of files piling up after the long patient journeys, and patients have very special problems. So I had the great honor to train with Mary a little bit, and I saw she also takes a lot of time, and it's so great. I think every patient that gets to see her, and I'm sure a lot of people are the same, are very, very fortunate, and it's like an hour per patient, which is basically not possible in lots of healthcare system settings. So this is something maybe we can also bridge at some point, but maybe it's also not, maybe we cannot do anything about that. And then also the research not reaching the patients and patients not knowing about the research. I think these are all things we can solve together. Yes, with ECRA, maybe, as a team player. So what is digital care? And I looked at the definition of the EU. And actually, if you change the order a little bit of the points that define digital health in the EU website, they all match the problems that we see, or they present potential solutions to the problems that we see in CMT. So expanding equitable access, advancing healthcare efficiency, care quality, will support healthcare professionals, and also empowering citizens, empowering patients to take part. And these are all solutions that are already out there, and we just have to grab them. And I really think the European health data space here provides a big opportunity for us to collaborate and to bring this together. And of course, national healthcare systems are going to be the first ones to have to implement this. And I've been living through the process in Germany. It's a very long process, digitalizing files, and things don't work as well as planned a lot of times. These are things we cannot really change now, maybe, but we can support the countries and the governments to support the rare disease and these kind of processes. And there's a lot of digital and devices and apps that we've talked already about a lot. Angelo has presented some amazing things. We have new technologies, and we also have some digital devices that are already accepted as digital clinical endpoints in studies, like the SV95, which is a tracker of the velocity of the steps that are done within a certain time period, and it's been accepted as an outcome measure. And I think this is also something we should look at more in the CMT world, and I know lots of people are doing that. So these are all really big opportunities for us to bring care to the patient's home, and also trials to the patient's home to make it easier. Telecoaching, also what Gita said, the project about teaching physiotherapists and providing patients with a connection to therapists is a great model. And other things are out there already in the CMT world. So some things we do in Germany, and I want to present a project that we are doing, is telemedicine. And I think this has lots of barriers. There's lots of things we cannot do with telemedicine, but there's also some parts that might be actually very useful and that we could use also in the rare disease space. And I've been very fortunate to work together in this project we're just starting now, which is about it's very German focused now, but just to give an example about the care situation that we have. If you look at this map, you see on the left side the population's age, and you see that then the eastern states of Germany, it's people are a lot older, and people who are older tend to have more neurological diseases. And then if you look at the amount of neurologists available in these areas, which are represented on the right side, it's a dramatic underrepresentation. So we don't have a lot of neurologists in these areas. I mean, Berlin is obviously an island of lots of people, but it's very small. We have this whole almost a third of Germany around Berlin that we have under very, very few neurologists per population. And all these patients are just underrepresented, and they pay the same healthcare fees, insurance. It's not fair. Why does someone in Berlin have access to a doctor within 5 minutes or 5 meters, and someone in the north can't ever access any physician, any neurologist, and they actually wait 8 months, more or less on average, for an appointment with a neurologist? So what happens is that they go to emergency rooms, and emergency rooms collapse because they can't care for them either. And this is only the top of the iceberg, of course, because this is, let's say, normal neurology, frequent neurology, and we are rare disease. So imagine what people with CMT in these areas are facing. They will never have a care, and no one is gonna really look at them. So I think these telemedicine projects, or projects that try to increase healthcare in rural areas or scarcely populated areas regarding neurologists, are very useful for us to look at as examples. So what the project does is try to bring the neurologist into the primary care physicians' offices. So in Germany we have this primary care system. We first go to your Hausarzt, your primary care, and they refer you. And instead of referring you to a neurologist here, they are provided with a little camera. They can also do it with their phones, but for now it's a little camera on a little wheeled thing. And the neurologists just call the patients via this camera while they're still in the physician's practice. To show a little bit more how this works, so let's imagine a patient who's seeing a primary care physician somewhere in Brandenburg, very far away in this little town. And the primary care physician thinks, okay, this is something neurological. I think I would like to refer this patient to a neurologist. So what they do next is they call the project team, which is 3 university hospitals in the area, and we at Charité, we are one of them. And they contact the teleneurologists, and they have these fancy equipments, and can also just be a laptop, or maybe they have big screens. And they can also connect to rare disease centers, which is nice. And this is where we might come in and say, okay, I connected to someone who knows about your disease. And then they can treat the patient who sits in front of this little camera thing, and also give him medications via telemedical receipts, or refer them to other specialists. And of course, we don't solve the whole problem, because we can't do neurophysiology telemedically. We can't really examine the patient. We can't touch them via the camera, but we can at least see what might be the problem here, and this might solve our first step. And you should maybe get a genetic test, which is something anyone can do. You should maybe see an orthopedic surgeon, or physiotherapist even, start some of the treatment or prescribe them something. Or maybe connect them to some network that might help them better. And so the big question here is, can we examine patients via the camera? Is that actually possible? And I know there's a lot of controversy about that, and I do agree. I think a lot of things don't work so well. But also there's some studies, also specifically in CMT, some in other neurological exams like the NHSS that have shown that lots of exams actually do work via the camera. Some basic things can be seen via the camera and remotely. And for example, in stroke care, it's been used widely already for some years. I know in Germany, I'm sure in other countries as well. I really like the study about the virtual CMTs, which shows that it's so reliable and it really correlates very, very well with the in-person CMTs. So we can do a very good outcome marker via the camera, and this is so valuable, I think, and we can use this to care about these people who are not in local and physical certainty close to a neurologist. And also we've done a little study in whether we can predict the patient's severity only by looking at how they walk, which kind of was a preliminary data for the Dancer project as well, because if we as a person can say this patient is more or less severe affected, a machine will do it even better maybe. And we saw that only by looking at the person walking and having some features that we look at, we can predict very well how the scores are in the very elaborate clinical examination that we do in person. So it has barriers, but some things might be able to be seen via the telemedicine. But still, there's a lot of problems. Oh yeah, something else I wanted to say, I already said this, there's some other things or some other applications that telemedicine is being used for already, which is rehabilitation. I saw Gita also when I was in London working via telemedicine, so I think it's been being used, but we could maybe use it even more. And yes, as I said, in stroke, it's very, very heavily used, and in emergency rooms where there's no neurologists, we can help making decisions as well. But there's a lot of problems, technological challenges. No one hates more than when the system collapses and there's this error sign. And this is something that's definitely a problem. Network availability is a big problem in Germany. In lots of areas, we don't have any connection, and it's not going to work. Internet is slow. We can't really see a good picture. That will not help. And of course, there is GDPR data protection problems if we think about doing this in an EU scale, especially. And data has to be shareable and documentable. Of course, we do not increase the number of people who know about rare disease by having more people connected to them, so it's still a bottleneck. We still have to educate more physicians or more healthcare professionals to know about these diseases to provide services. We can't now connect all Germany to one specialist clinic, but it's a first step maybe. And then, of course, I was thinking, why can't I refer my patients to some other countries that might even know more? And there's, of course, language barriers and also reimbursement barriers. So who pays if I'm insured in Germany, but I want to go to Italy for consultation because that's the specialist. So a lot of problems still there, but we could tackle those. Some other things I just want to present very briefly. There's apps and devices that are that might help us to remotely monitor the patients better and to save time because records might be easier sorted already, save all this big paperwork, and make it searchable and easier to quantify for research as well. And there's 3 projects that we use or that come out of Charité because some people thought about these things, and I'm sure there's so many more solutions that might be interesting. But these are 3 things that we kind of start using a little bit. And one of the projects, it's now focusing on myasthenia gravis, but it's a very nice tool, I think, to monitor people at home, give them the ability to enter prompts and vital capacity, for example. And connect them to specialists. Then there's documentation also for sending out questionnaires to patients. Also, there's applications which are now specialized on ALS that are helping patients to get care and devices to help them at home. So lots of solutions we could use. I'm sure other countries have other devices or solutions ready for them as well. But of course, as always, there's the problem, do patients actually use these? Is this a bit annoying, having so many different things and apps on their phones and devices they should use? There's a little graph that shows that in this MIA link for the myasthenia gravis, people adhere pretty well, but it's only an example, and I think at least all of us who are patients know it's not very, like we have other things in mind too than documenting our health state every day. So it has limitations. And of course, as we talked about earlier quickly, it has to be financially sustainable and someone has to keep it going and pay it, otherwise it's gonna die. So lots of things we have to think about when we think about making things scalable throughout Europe and throughout our countries. Last, I want to talk very briefly about registries, and this is a very hot topic, I think, for everyone, because everyone wants to have a lot of big cohorts and good clinical data in it, and there's been a lot of work on that. And everyone wants this, so maybe this is also an opportunity for us as ECRA to get together and look for some new opportunities to share our data and combine our registries. And this is a very busy slide about ideas or things that come to mind, because I feel like everyone is using REDCap and we can so easily share instruments on REDCap to collect clinical data. We have the great training programs by Kyla and Josh who show us and train us to do good clinical data collection. And if we use the common data sets that are already established by the ERN, for example, only document during our clinic visits the patient's gene, the patient's CMT, and maybe the age and sex. And this is already a great data bank if we know, okay, where is the data, and we can then ask to access it. Maybe use the ERN as a data hub to combine all our registries. And of course, the INC is doing this in a great manner already, and I think lots of people are very interested in joining and contributing their data. There are so many different projects that are going on, so maybe ECRA is an idea, a good opportunity for us to get together and see and understand, also for me, for example, to understand better what's going on already, how can we contribute. And I'm very happy to hear everyone's opinion on that, on concrete actions on how we can put together our data, and also, of course, make it shareable for all and accessible for everyone who wants to do studies. So in the ERN, I think it's a very good idea to have a committee that looks at study proposals and asks all the participants whether they would be able to share their data. Everyone gets their co-authorship, and a person gets to do research on something that helps everyone. So we can discuss that. As I said, lots of very big challenges also. But first of all, we need the FAIR principles to be in place, and that's also not easy. We have to reconsent patients maybe to make it shareable across borders, across universities with our data that's already been collected. But I think it's good if we move forward to already think about these FAIR principles, to think about common data formats, to think about doing it in HL7 FHIR formats, or just use REDCap, which is kind of providing it already, to think about ownership and shareability, and making fair guidelines on how to access data. And of course also language. So we can, maybe when we collect in our national registries, already have a little English translation in there, so we can have a common language to also make our data more shareable. Yes, as I said yesterday, lots of opportunity for joint projects, and I think we've already have collected some ideas. Play the video again so you can see this very cool figure. I just love watching it. And looking forward to everyone's thoughts. Thank you so much.
Thank you so much, Helena. Are there questions? Michael Shai?
Thanks for a lovely talk. And before my question, just a quick thank you for listing the INC. But it should be noted that it's supported now by the Charcot-Marie-Tooth Association. So thanks to them.
Thanks so much.
So with the research side of things, I think it's also worth noting the infant toddler scale, which is now able to be done remotely, which is very nice for young children who often, particularly if they're severely affected, have a tough time getting to clinics, so you can actually do these evaluations at home. And again, getting back to Josh and Kayla, both the virtual infant scale and the virtual CMT exam scale are available for everybody already and online, and I always forget the link, but both the scoring and those scales are there with training modules.
Thank you so much for that comment. I think we should definitely put those up on the ACRA website or something, so everyone who's an ACRA member at once has access to those. And as you see, I didn't have this in mind, so thank you so much.
Thank you. Are there more questions? Yes?
Hi, Helena. Wonderful talk. I think the financial aspect is, as you mentioned, crucial. Here in Belgium, during the COVID pandemic, there was a temporary reimbursement for this telemedicine. And we noticed in the hospital that it was really a big relief, to be honest, to have patient contacts without, sometimes it's very brief, it's only 5 to 10 minutes even, but just have a brief contact with the patients without them having to come to the hospital. I think for research, but also for the general practice, it's really important that these kinds of brief contacts even are very valuable. So I think we have to try to search for strategies to convince governments that this is really cost-effective. So I don't know if you had experience in Germany with this kind of discussions with the government or reimbursements agencies?
Yes, thank you so much for that comment. I think that's so important. And I think this also happened in lots of countries, that during COVID there was a lot of possibilities, and afterwards, for some reason, they scaled back, even though it was so good for everyone and it saved money and everything. And so actually this project that I presented you, this is some way to try to implement it into the insurance system. So it's called Innovation for, and it's insurance systems who finance projects, and we try to, like with a big budget, and we try to implement this into the regular care. So it's a trial. It's randomized. One half gets this telemedical treatment, the other half gets the regular treatment, and the outcome is how many people go to the emergency room. So I think with these kind of studies, we can convince governments better, and payers most of all, which probably make the decisions, that telemedical structures are worthwhile. As always, it's about money a lot. So if we do more of these projects, and we try to also maybe in the CMT community do these kinds of projects and show we can save money in randomized trials. Of course, we have a small patient cohort, so it's going to be harder, but these things might help us. Thank you so much.
Any other questions? Over there. Yeah.
In France, it's reimbursed, the telemedicine. So we have used it, but sometimes I like to have the contact with the patient. So for once, I could have a talk with my patient through this telemedicine, but I like to evaluate them, to speak with them. It's not the same thing, you know. And for the GP, we try to educate them, you know. But many GP-oriented patients towards orthopedists, you know. So I get my patient CMT through orthopedists, you know. So it's very difficult, but the simple things, they have so many things to do with the GP. And then, I don't know how it's in other countries, but in France, we lack GPs. So we lack GPs. So there are so many things to do for them. Diabetes, hypertension, vaccination. So they don't think of a rare disease, you know. So even I ask sometimes, just tell me what is the level of CK. I don't have that, you know. So I don't know. I try to educate them, but it's huge work. So I think we should spread more specialists for rare disease. It's important in every big town to have one specialist, or in middle also town. We are all well organized in France. We have spread specialists for rare disease. It's something that we can do. But GP currently in France, it's very difficult because there are few GPs. There are some areas in France you have no more GPs, or just one, and they have a lot to do.
Yeah. Thank you so much. I think we just have to make it easy for GPs, and they don't have time. So we have to help them help us.